Ladies and gentlemen, welcome. This is the healthcare panel, and on behalf of MIT Sloan CIO Symposium, I welcome you. And we have a great set of panelists, and we'll talk about transforming digital silos to digital care enterprise. So what do we mean by digital silos? So I'll pose a question and just hand it over to Shahid Shah. He's the moderator. Then he will drive the discussion. When the Obamacare, or what they call the healthcare website, was it due to digital silos problem or it was a design problem? So we have healthcare reforms. Everything is going through the digital side of it. So how you integrate and have a seamless collaboration among them from the enterprise perspective. So this panel is all about how different systems, policies, people, technologies all play together. And with that note, I will pass over to Shahid Shah and let him drive it. Shahid.
All right. Thanks, Naeem. So how many of you having a good time? All right. I think food has something to do with that, so it's good. We won't have to compete too much. So my job really as a moderator here is to make sure that you're not bored and don't run out of here right after you finish lunch. And hopefully with this panel and the participants here, that's not going to be too hard to do. We're going to run things a little bit differently than the other panels of the morning, and that is we're just going to ask for very quick introductions from all of us here. I'm going to set the stage for what the topics are. And then those two microphones will be immediately opened up for questions. Last year we did that, and it worked out really well because there were a lot of smart people in the audience that wanted to drive the conversation in directions that perhaps we weren't prepared to do, but we're going to do that. So before we answer Naeem's excellent question about Healthcare.gov, just a quick introduction of what we're trying to do. My name is Shahid. I'm a health IT blogger and enterprise architect that has been working in healthcare for a long time. And my experience over the last few years on digital enterprises, moving healthcare from its different silos, et cetera, into a more unified digital enterprise has come with mixed reactions, I'm sure, as all of you have probably seen as well. And some of the difficulties, the problems associated with them, those are the things that we're going to talk about today. Digital enterprises are supposed to include the patient in the middle of all of our discussions, something that has not always been the case with information technology in healthcare in the past. Digital enterprises are supposed to integrate with partners in a more unified supply chain, which of course has not always been the case. For example, the supply chain in healthcare includes things like referral partners, includes things like imaging partners, et cetera. And we hope that in the future, these digital enterprises that we're creating are not focused on creating more and more silos of digital information, but some unification. And of course, in a $2.3 trillion industry, nothing moves fast, and we're not going to see healthcare moving that rapidly either. To help the panelists get a sense of who's in the room, how many of you are already in healthcare information technology in some way, shape, or form? All right, so we don't have to start with any basic type of stuff. How many of you come from the care provider, nurse, physician, you touch and talk and work with patients on a regular basis? Not just even a few. Oh, yeah, we see one or two. That's great. And so it sounds like everybody else is more on the tech side. So now you guys have a good idea of what the audience makeup here is. So as I mentioned, we're going to talk about the digital enterprise. But what I wanted you to do was to think about the topics you had heard this morning, and based on those, if you have some burning questions, if you're an innovator wondering what area to get into, we've got, of course, Darrel sitting here from the state, and if you've got some questions around policy and stuff that you'd like him to change on the spot, I'm sure he'd be willing to hear about that as well. We've got everybody here is a CIO, so you've got the right crew. But we are going to ask you to, jump up and ask questions pretty early in the stage. So as soon as your mouth stops moving and the food has been chewed, be ready to do that. So with that, I'm going to just ask, starting on my left, Bruce, just a couple of minutes of introduction. on your side about your experience over the last couple of years trying to move to this more unified digital enterprise, and then of course with Kristin and Darrel we'll do the same thing, and then we'll jump into our questions that Naeem posed.
Well, thank you. Good afternoon, everybody. Welcome to our session. My name's Bruce Metz. I'm Senior Vice President and Chief Information Officer at Lahey Health. Just so I know, how many people may be patients of Lahey? Good, good. Come talk to me afterwards if there's any issue that we need to know about. I mean, for those of you who are in health IT, this is a phenomenally exciting time to be in healthcare, and even if you're not, I'm sure you know healthcare is undergoing a radical transformation. Just real quick to understand the digital enterprise, 3 mega trends that are driving this. One is complete industry restructuring, starting with how we get paid. That's getting turned upside down. Rather than fee for service, it's now feed for value. There's also huge advances in medicine on our horizon with personalized medicine and genomics, which will change dramatically. And probably the most important is all of you, and really a move to consumerism and empowered consumers. So that set of forces is really setting in motion a huge effort nationwide, and particularly, and rather quickly compared to elsewhere in Massachusetts, to change our fragmented, non-patient-centered, disease-oriented healthcare system to one that's based on preventative care, wellness, and really patient engagement. And to do all of that, the wonderful part about being in health IT is that advances in technology, in addition to consumers, are really probably the 2 primary drivers that are making this happen. And in a digital enterprise, what we're finding is, if you look at the evolution of IT's role from an installer to integrator to what we typically do to enable things, it's really to be an innovator and driver of business growth and success, where the technology in itself is a fundamental creator of value. And that's what we're trying to get to. But if we did that alone at Lahey and other enterprises, we'd have a better enterprise system, but we wouldn't do much for the healthcare system. So just in terms of your reference to the supply chain, we also need to work together with all the major stakeholders. And healthcare is 20% of the economy, so this is rather huge, between payers, providers, consumers, patients, policymakers, government agencies, and researchers, to really affect a completely new integrated healthcare ecosystem, where there's much, much more integration across those stakeholders, a great deal of collaboration and coordination, information sharing and sharing of other digital assets, so that healthcare can take place not only in the traditional walls of a place like Lahey, but any place at any time on 24/7. And the tipping point for that will be when we get to really a predominance of wellness and prevention, and personalized medicine is mainstream. Now, nobody knows how long that's going to take, so this is quite a journey. And thinking about this, just the 3 real key conditions that we have in Lahey that I think apply elsewhere in order to do this. One is, in order to not have digital silos, you can't have clinical silos. So there needs to be a strategy and an execution on that strategy to have a single integrated model of care. Lahey was founded in 1923. As an integrated delivery system. So we kind of have that in our DNA, but it's to have one standard of care across the enterprise. Second is to have a real fusion between IT and business strategy. So it isn't business strategy and then IT something out on the side. One won't be able to really get the value that IT creates unless the IT and business strategy are melded as one. And thirdly is, because the change is so great, is really to create a core competency in our enterprises to be innovative and to innovate. And for those of you in healthcare, you probably know, I mean, that has not been a hallmark of healthcare, largely because of funding levels. But we really need to move to much greater competencies in innovation. And if we do that with an integrated clinical strategy, and then also with a fusion of IT and business, I think we got a real trajectory to get to our digital enterprises, while we also work on that ecosystem I talked about.
No, that's great. And so up next is Kristin, but that was a great introduction. Did you want to give a little bit about Lahey itself? Number of patients, number of beds, number of facilities, sure. Just to get a sense of that?
Yeah, so I've been at Lahey for about 3 years. When I joined, we were called Lahey Clinic, and all my close friends and associates said, well, that's a great move. Healthcare reform, anybody with clinic in their name's going to do well. May of 2012, we became Lahey Health System because of what's going on in terms of that whole industry transformation. So we now have 6 hospitals with another one waiting final regulatory approval. And assuming that goes through, we'll be about a $2 billion organization with about close to 1,000 beds across all of our hospitals, about 900 employed physicians and 500-600 independent affiliated physicians. We have about 30,000 inpatient visits a year and over 1 million ambulatory visits a year. So it's a very robust, active health system. And our reason for coming together as a system, apart from the pressures that the industry has experienced, is really that we believe deeply in keeping care local, that most people, if they can, would want to get their care as close to home. And for those of you who live in the Boston area, we're blessed around here with phenomenal health care. And so what we do in our system is partner with high-end tertiary hospital that Lahey Clinic has always had, with community hospitals who also have a tremendous service to their community. And what we found is by really right-sizing where the care goes between our community hospitals, our ambulatory practices, and our acute care hospital, we're really able to deliver higher quality outcomes at a lower cost and with a higher patient experience. And we're starting to get data that really supports that.
Very good. So you heard, Bruce is leading a fairly large organization, but some of the questions that you should ask of all of us here are, based on the things that a large institution learns, how can you apply it to the smaller ones? Or based on what the smaller guys know, how can the larger guys pick it up? So as you're starting to think about the questions you'd like to pose, definitely think about that. Kristin, quick introductions.
So thank you for having me. My name is Kristen Derby, and I'm the Chief Information Officer of Cancer Treatment Centers of America. I will note that I joined that organization about a month ago. So in some of my introduction here, I'll be talking about some of the past experiences I've had. So I've spent the last 20 years in healthcare, and as we talk about digital silos to a digital enterprise, certainly have experienced that transformation and understand how it's affected the overall patient care that we're able to deliver. As the picture of a patient's care has started to evolve, where there's much more information available. As patients become mobile, it does not have to be their responsibility to transfer records or make sure things are happening. We're doing much better as an industry, but we still have a long way to go. I've worked on the ambulatory side for a large portion of my career, but have also worked in an acute area where I had responsibility for 9 hospitals. On the ambulatory side, I had responsibility for approximately 2,300 outpatient clinics. So large national focus and certainly understanding patient mobility and the need for that information to travel frequently across state lines, and making sure that the ease of use for any type of care provider is there. As I've transitioned, well, I'll say from the digital enterprise side, from the acute setting, I had exposure primarily in Massachusetts, Connecticut, and Illinois. 3 very different markets from a maturity level. Certainly the Massachusetts area is a little bit farther along with a lot of interoperability, and the care continuum being much more mature in this particular market than it is in some other markets. The benefit of that is I find in Massachusetts there's a lot more collaboration from a technology side around coordination of care for the patients. In addition to that, there's much more of a mindset of understanding that the data belongs to the patient and it's there to facilitate their overall care. That thought process is still evolving in other parts of the country. And as technologists, we continue to push that agenda, but we certainly have to continue to partner with the clinicians that we work with and make sure that any type of technology we're introducing is supporting the clinical process that's being provided to patients and is really facilitating that overall patient need. From Cancer Treatment Centers of America, we are 5 hospitals throughout the United States that focus on adult cancer care, typically very complex cases and advanced cases for patients that have determined that they have elected to go to a facility that provides that type of specialized care. Myself, having many years of experience in healthcare, they focus on what is called the mother standard of care. The organization was founded by Dick Stevenson, who's lost his mother to cancer in the 70s. And one of the things he saw through that process is that there had to be a better way to personalize the care, make sure somebody had dignity while they were going through the process, and really had an individual personalized experience. So based on that, he founded Cancer Treatment Centers of America. And I will tell you, as somebody that is a non-clinician but has spent a lot of time in hospital settings, it is absolutely amazing the way these patients are treated. And the level of care is known as the mother standard of care. So every patient will be treated the way you want your mother to be treated, your father, your brother, your son. And it's an amazing experience to actually watch that occurring. It's something that I think we all hope to do that are in the healthcare industry on a daily basis, but I have never seen it achieved at this particular level. So taking that particular type of focused care for the patient and then translating that from a strategy perspective, from an IT side of how do we make sure that the clinicians throughout that continuum, when they come to us, they're often very sick, and when they leave to go home, may not be fully recovered. How do we make sure we're supporting that entire process and partnering with providers possibly in the hometown or other types of specialists that need to be coordinated with? So it's certainly an evolving area, and one of the complexities that I mentioned that certainly lends itself to Cancer Treatment Centers of America is the fact that we are crossing state lines. So when you talk about HIEs or the evolution of direct interface with referring physicians, that is very different state by state as to how many doctors are prepared to be able to accept those types of interfaces. So it's definitely an area that, from a standardization perspective across the US, has a lot of maturity, and I hope we can talk about that further here today.
That's terrific. So what you heard from Bruce was, again, large integrated systems. They have their own set of benefits and problems associated with them. And so Naeem and the MIT alumni here did a really good job of getting a good set of facets of different views, because it's a very, very complex story here from a digital enterprise perspective. So as you're asking questions, think about it from an integrated system perspective. With Kristin, you hear from a specialty care case when the hospitality side is just as important as the treatment side, and where does technology play a bigger role in the hospitality plus treatment, or just the treatment side, because there's diagnostics, there's therapeutics, there's treatments associated here. And now with Darrell on the third leg of our panel here, you're going to get the government viewpoint from still focused on practical health information exchange kinds of ideals. But as you're starting to think about what questions you want to ask and the areas that you'd like to focus on, do keep in mind we've got those three very nice independent viewpoints and facets. With that, Darrell.
Thank you, Shahid. Good afternoon. That's two very tough acts to follow here. Hopefully I can keep my end of the bargain up. My name is Daryl Harmer. I am the Associate Chief Information Officer with the Commonwealth of Massachusetts Executive Office of Health and Human Services. So I think I've used up my minute just with the job title introduction. I've been at HHS since January. I've been with the state since the mid-'80s. I started when I was in kindergarten. And I've been in IT for most of my career. So for me, this has really been coming from an IT background in a very large, very diverse enterprise, and now applying that to a healthcare IT setting. So my primary focus is to complete the development and implementation of the state's health information exchange, or the so-called Mass Highway. Can I just get a quick show of hands of how many people here are either connected to the highway or are trying to connect?
So seconds here. It was.
Okay, one. Okay, so we have some
I
work.
think you have one more back
Yeah,
here.
I'll read
All right, so we have some work to do, obviously.
You could take a minute to describe the highway.
Yeah, so the highway is a health information exchange that we began implementing, I think in the fall of 2012 when Governor Patrick made what we call the Golden Spike event, where he actually sent his health data from Mass General, I think it was to Bay State. That was the first time we'd been able to do that. Since then, we have focused on driving the implementation of the highway. It's based primarily on the ONC direct protocol. We have 3 ways to connect: webmail, and then direct, and then finally a device that we call a LAN device, which is essentially a converter box that we can drop into an institutional setting, and then essentially you can just drop your files on it and they'll get sent to wherever you need them to go. So our goal is to leverage the highway to accomplish 2 primary policy objectives. One is to help improve healthcare outcomes, and the other is to lower healthcare costs. 2 sort of critical foundation pieces of what this administration is trying to do in the healthcare field. We are sort of in the beginning of the walk on a crawl, walk, run continuum. We've had it up and running for a couple of years. We're focusing now on stabilizing it, operationalizing it, trying to make it easier for providers to connect to it. Now it can be a bit of a challenge. We definitely need to simplify that, especially as we try to expand usage beyond the sort of large institutional settings, Beth Israel Partners, Lahey, and so on, and get down to some of the smaller solo practices or 1 or 2 doctor practices where they may not have that deep IT expertise, and they really we need to get to the point with them where there's 5 steps, 10 steps, whatever, but at the end of that list of steps, they'll be connected. So as I think Shahid or Bruce were saying, we definitely view this as a long-term initiative. This clearly isn't going to happen overnight. I think at this point, we have about 100 providers that are actively connected to the highway. They've signed participation agreements, and they're actually using the highway to send mostly quality data at this point and some clinical data. We are also hooking our public health registries, so for example, immunizations, syndromic surveillance, things like that. We're hooking that into the highway, so that'll be the primary transport for that kind of data. And so at this point I think of the year and a half we've been live, we've gotten about 2 million transactions. There's a steady upward curve that we're really looking to push up over the next several months to a year. So, coming more from an IT perspective, before this job, I ran the state's IT capital program. So we funded a lot of the state's strategic IT projects, some of which you've unfortunately read about in the papers over the last few months. And then before that, I was in senior IT roles on several enterprise projects, ERPs, our HR and finance systems. And then before that, I was what we would now call the CIO at the State's Group Insurance Commission. So, the issue of, consolidating digital silos is one that I've obviously seen. In state government, if there's a silo to be built, we'll build it. Now we need to take sort of the opposite tack and really start to bring those together. The state itself has several large healthcare-related databases, the all-payer claims database, the Medicaid database, the state's employee claims database that, over time and in the right protected settings, we're really looking to integrate those. One of the other features of, I guess we'll call it a feature of Massachusetts, is that We are what's known as an opt-in consent state. So from a patient perspective, for a provider to send your data over the highway to another provider, the provider needs to get consent from that patient. And so we're working with providers to try to simplify that process as much as possible. Right now, consent is a fairly coarse-grained level, that it's basically a binary yes or no. The literature talks about in the future that consent needed to get much more granular, and from an IT perspective, that scares the hell out of me, and how we would even implement that and how we would manage it, how patients would understand that I'm saying yes for this, no for this, and being able to understand. So there's a lot of work there to be done. So it's a fascinating field. Those of you that are in it know that, and I'm looking to get more into it over time.
Yeah, that's great. So with Darrel, we have someone who's been on the state side.
In the interest of full disclosure, I cannot change policy from,
I'm
from
just
this
joking
chair.
about that. So you see someone who's been in IT for a long time, just now getting into seeing some of the uniqueness or the mess that we have in healthcare. So with him, any questions you want to ask about that transition is actually a good one. One thing to think about in healthcare, especially when you heard a lot of the panelists this morning, with their specific challenges of moving from silos to a digital enterprise, is that typically you don't have to do the kinds of things that, and I'm glad Darrel mentioned it, is this idea of consent. When supply chain partners in other industries start to share information between businesses, they don't worry about whether or not their customers are going to mind that data being shared in the same way that participants in healthcare have to worry, do the patients mind having their data shared in many ways? So when you have some questions about that consent, without proper consent and without proper privacy, as far as basic policy is concerned, there will be no digitization of the enterprise in healthcare. So we're talking about many years of this to be still done. A lot of policy still needs to be worked out. And some of the things to think about from an innovator's perspective is all the problems that you're going to hear about do have solutions in both the digital realm as well as the policy realm. But at the same time, we don't have to wait till policy is done to even try some things. I mean, one thing that we've seen the federal government be a little bit better at over the last maybe 5 to 7 years has been in experimentation. So if you have an idea, the experiments are being run, you'll hear pilots upon pilots being run for many things, and in fact, many of us are piloted out because we see so many pilots being run. So one of the CIO award winners from last night said Naeem is the godfather of healthcare IT. I want to make sure we got to his we got to his question.
It's all his fault.
It's all his fault. That's right. Well, I wanted to cover his question. You see, with the Affordable Care Act, with Healthcare.gov, lots of things happening in the same way that they're happening in many of our institutions. Major policy changes. New participants have to be brought in. We're trying to sell things. We're trying to build a website and doing all of this very rapidly. I mean, from a budget perspective, it's about $350 million worth of attributed budget to Healthcare.gov. But I did want to open the question up because Naeem did ask a good question, and that is, with what happened with Healthcare.gov, what, if anything, do you guys take as CIOs in your respective areas from your health information exchange background? You know that a lot of what happened behind the scenes at Healthcare.gov was integration problems. It wasn't that we didn't know how to write HTML or JavaScript and the website, quote, broke. There was a bunch of stuff that had to happen. Silos had to be connected, and that was there. Kristin and Bruce, you guys know putting together large systems for large-scale usage is very, very difficult. So what did you learn? Maybe we'll start off with Bruce on your end. What do you think we learned from the Healthcare.gov side that everybody here can use as they're building and innovating or trying to move into the healthcare market?
Well, that's a
we'll start off with a simple
long answer question. So 50, 55 independent contractors with no project manager. And who do they blame? The CIO, who had nothing to do with the project, from what I understand. So, I mean, if you do a large, complicated project, and that's probably underfunded as well, with that kind of lack of organization, it's not going to be difficult to predict the outcome. Plus, if one lets the time frame drive the completion, as opposed to whether something's ready to be released. And the other facet that I always a little surprised about, probably shouldn't be at this point, is healthcare is unbelievably complicated. I think decades ago, Peter Drucker said a hospital back then was the most complex form of organization, probably even more so now, that people sometimes tend to underestimate that level of complexity in order to do something major, because historically, since healthcare IT has been so underfunded, maybe 1 or 2% at best of operating budgets and revenues in a lot of organizations, that's not enough in order to get really industrial strength enterprise infrastructure or applications. That when you try to do something that big that connects a lot of old things, you're sometimes better off knocking the pieces off the chessboard rather than trying to do that. But I have no doubt that maybe not years from now, that'll be a Harvard Business case study or an MIT Sloan School study, because if you could do something wrong, that certainly did it. And we have a lot of enterprise projects going on. And so as soon as I said, oh goodness, okay, so the board is going to ask me, how are we doing A, B, and C? But we're very, very careful, as I'm sure organizations of my fellow panelists here, of making sure we have a whole program management office that stewardships projects from beginning to end. And as much as we want to get look at the big picture and the excitement of what it would be to have a new healthcare ecosystem and to have a digital enterprise, they're built one project at a time, and they all have to be done with really rigorous standards and very tight project management, and be funded appropriately, and really have the scope nailed down, and make sure that when one goes live, you do it when it's ready, and not just because the clock rang.
That's great. Remember, right after this, you guys can come ask questions. So if anybody wants to ask, go ahead and start lining up, or we can try to pass the mic around if that's easier. Kristin, what do you think we learned, or what would you have learned personally from Healthcare.gov? Do you use it as an example to your staff at all?
I have not. I think because it was such a large, complex project, in particular zeroed that one out, but it certainly has commonality with many of the projects that we've operated. I think Bruce hit on many key points that were issues, and you know, as we continue to learn more, I think there's more and more breakdowns that contributed to that. But one of the things I compare it to is you know, the interface complexity problems that they were having were related to trying to deliver too much, I think, that the marketplace didn't necessarily need to be able to accomplish their primary goal. And it's part of, I think all of us as we sit in the CIO role are faced with our peers and the user community always wanting what I'll call the next sexy technology item. And they don't always understand the underlying complexities related to how to actually implement that in an environment, the cost of that, and what's required from a methodology and process perspective to implement it within the environment effectively and to be able to test it. You know, I think one of the most amazing things I walked away with is they were opening this up to the whole country, which is a significant load with no load testing, which is just, you know, I think there was a whole line of issues just up to that point, but the fact that they turned the switch on without that to really reconfirm the fact that they weren't ready was really a disservice. The organization I was with previously, we certainly had created a new insurance product that we thought brought a lot of value to the state of Massachusetts, but our CEO there, his comment was, the store is open, but the mall's closed, which I thought was actually fantastic because we couldn't believe, you know, how much work went into meeting that deadline, and then no one could actually access the site. So, you know, from a process perspective, I think all of us as taxpayers have to continue to push back on the government to use better methodologies and make sure that the investment of our tax dollars into those types of initiatives are being well spent.
So, Darrel, speaking of the government, what did you guys see? And again, from your personal perspective, what you saw, what do you apply from it? Do you use it as an example to staff?
So, unfortunately, in terms of using it as an example, the state level, we have many of our own examples to point to. One of the things that actually has always amazed me about Healthcare.gov is, at least from the you know, the front end perspective, how quickly they actually were able to get that in at least a semblance of order. I think everybody knows here we've had our own analogous issues with the state's health insurance exchange that we have not gotten to the other side of yet. I would sort of echo Bruce that the number of integrators, the lack of project management, the lack of clear business engagement. And then I think what we sort of tend to forget is that a lot of these projects are trying to integrate and get systems to interoperate that were not only never designed to do that, in some cases they were almost designed not to. They were really almost designed as closed systems. And opening them up is really pretty challenging, that in many cases there's no one that fully understands the data structures or the data contents. At Health and Human Services, we have 17 agencies. They all have their own systems. They all have different occurrences of the same person's data, but in potentially different IDs, different formats of the name and so on. And so to pull these systems together really requires a level of governance maturity and sort of ownership maturity that in a large organization, especially government, to be honest, we're not there yet. Right. And so to bring these disparate systems together in ways that were never really envisioned when they were built, we can't underestimate how hard that is. And you'd read things about somebody saying, well, Amazon was able to stand up a website. Well, okay, great, but what they had to do with Healthcare.gov, what they're continuing to have to do is, orders of magnitude more complex than that. So, as an industry, IT clearly needs to do better in implementing these systems. The analogy is often used that building IT systems is equivalent to building roads and bridges and buildings, and the analogy falls down, in large part because we've been building roads, bridges, and buildings for thousands of years, and we've only been doing IT since, say the 40s or 50s. But we've been doing them enough now that excuse, I think, is really getting tired. And the analogy I always use would be like, if we built a bridge and then watched it fall down and then just, well, that's how bridge building goes. These things happen. And we need to get sort of away from that to, we have a broader understanding now, what it takes to build these systems successfully. And that we really have to sort of put those lessons into action and, really start acting on them.
Yeah, that's a great point. So we'll jump into our question here, but as analogies go, I often like to use the analogy more, especially in healthcare, this is the case, is building these kinds of systems are not so much like building buildings, which we've known for a long time, but they're really like movies. If you look at all the constituent pieces of every movie, they're all the same. You have actors, you have directors, you have sets, and you have cameras, etc. But not every movie comes out really nicely, does it? Some when you put them all together, they come out really, really nicely, and the vast majority of them, unfortunately, don't. And that's why that's how I see these happening. Is we build software routinely, but not all of it always comes out because of a lot of problems on the back end. Our first question, go for it.
So, overall, you guys have talked greatly about some of the key areas that I've dealt with when dealing with hospitals as far as the business architecture and some of the things that are in play. One of the, I don't know if it's a law or something that happened back then, is the high-tech, I don't think it's a law per se, but high-tech initiative for meaningful use that got a lot of the healthcare to do implementations of e-prescriptions and so forth. Has that helped you guys? When you're looking at the highway and how it's actually being transferred and moved, did that help you break down those silos, because it is now involving a lot of different partnerships, a lot of different business integrities and so forth? Did it help you identify them first, and then how did you actually kind of get over that and start integrating those things together?
So let me give you just a quick, in case you're not familiar, the High Tech Act, which was released in 2010, focused primarily on trying to get people who weren't already users of technology to jump on to electronic health records. We've been promised electronic health records for many years. The idea was that if we incented them with money through higher reimbursements, that would move the industry faster than they would have otherwise moved. And I think, in general, the answer to that has been true. But I think it'd be a great question for each one of you to say, what of the high-tech, so high-tech, it's here to stay, there's nothing changing about it anytime soon. We got the technology acceleration, but did the clinical acceleration, I think, Bruce, you said it well, is that if you don't get the clinical integration and that clinical acceleration, the technology, yeah, we can toss stuff in, but it won't necessarily work. So I think the meaningful use and high-tech question is great. What do you see it as? Do you see it really as it just accelerated and now we're back to the same problems, only bigger? Or did it accelerate and actually improve and now is a really good building block that we can build on?
Sure, I'd be happy to. I think it's a great question. Federal government, as part of that, pumped in about $38 billion into health IT, part of it in health information exchange, but the lion's share, as we mentioned, in electronic health records, which is fantastic. I mean, that brought a spotlight into what needed to happen in the way of kind of really escalating the pace and the degree of activity to create a digital care enterprise, which in provider settings starts with an electronic health record. We happen to think what we're trying to do is create a digital care platform, which is a lot more than that, but that's certainly at the heart of it. And I don't think anything could go back. And what's happened is, with meaningful use, it has stage 1, stage 2, stage 3 with certain time frames, and then providers get incentive payments based on meeting those criteria by certain times, and by 2016 or so, CMS, which is the kind of governing body for that, would start to institute a penalty based on your overall government billings if you didn't have those capabilities in place. And CMS never instituted a penalty before, so people are thinking, are they really going to do that? But what happened is, along the way, the bar for what organizations had to do to meet meaningful use in the criteria, stage 1 was kind of lower level. Stage 2, which is what we're up to now, got much higher, and stage 3 is way out there. And because of everything else that's going on, if that was the only thing going on, I think people would be a lot more receptive. But in terms of keeping the engines running, in terms of all the other regulatory and compliance requirements, of which some of you may have heard of something called ICD-10, which really changes the billing and procedure codes that we use in order to do research and also to get paid. That was supposed to change October 2014. It was an old system, about 18,000 codes. It was going to go to about 140,000. It's a minor jump. But that got pushed back to October 15, but that's going to happen. That's going on at the same time. In Massachusetts, there's mergers and acquisitions. Nationally, there's over 100 mergers and acquisitions of hospitals and healthcare organizations, way more than double or triple 2012 than there was 5 years before, so you have to deal with that. And then all the other aspects of healthcare reform with the payment model going upside down. All of that together creates an unbelievable set of challenges that when the bar for meaningful use got set much higher, organizations started to really push back. And so there's now word out of the appropriate federal government agencies that they may relax the requirements or push back the date, because many organizations that had tested for meaningful use stage 1 are not going to try it for stage 2 because it would become too onerous. Mm-hmm. The thing is, once you get on the train, then there's a penalty if you don't stay on the train. So, mm-hmm. But that's kind of a tactic, but big picture, it's absolutely fantastic that the federal government made that kind of commitment, because that's the direction that we need to go to. Albeit we need to go at it in a much more coordinated way, so we don't do it in a way that just produces a different form of Swiss cheese in silos. But without that impetus, I don't think we would have close to the same attention that we have on it today.
Did Lahey end up accelerating anything on its own, or were you guys already on the move and it just so happened you got more reimbursement?
We were on the move. All of meaningful use in the ARA Act and high tech really accelerated what we're going to do, not just because of meaningful use part, but it also really put a lot more teeth in the security and privacy and regulatory part, mm-hmm. because there are now criminal penalties if you really willfully neglect what you do. So it really jump-started in a lot of ways, but the biggest driver for us is really the transition from being a clinic to a system. Mm-hmm. And in order to have a single standard of care across the system, we needed one integrated electronic health record to be one integrated digital care platform that we would do anyway. Because meaningful use in a lot of ways really says do the right thing for the patient, and CMS and others are helping you define what the right thing is, and it's kind of the minimum. Some people call it minimum use instead of meaningful use. We do much more than that. And most provider organizations, particularly in this area where I mentioned they're phenomenal, will do much more than that. So we would get there, probably not as fast as this is propelling everyone.
Cool. So, Kristin, in your past organizations, did meaningful use drive you to do things you wouldn't have otherwise done? And how about at cancer treatment? Does it play a role in what you work on a regular basis, or is it just noise on the side?
So I'll say at cancer treatment centers, I'm still evaluating the meaningful use, but I think it has the same implication that you have to meet the regulatory requirements, but it's looking at it from a specialized focus. So it's not quite as broad as my previous role with Vanguard Health Systems, which became Tenant Healthcare. And you know, the situation is, I absolutely was doing many, many things that would not have normally been on my agenda to meet meaningful use. And
But that was driven by management, or you thought that that was the right thing to do?
it was driven by regulatory compliance to
Okay.
meet meaningful use attestations. And I found it to be, from an industry perspective, I think it's very depressing that we've had to have something regulatory enacted to enable us to move forward in a digital way. And so what that's ended up creating is a very subscribed, standardized implementation across all facilities. So if you look at a community hospital versus an academic versus just a tertiary care center, they all have different needs, and we're all following this same menu of implementations that may or may not be the best thing for our particular facility and our patients. We all have different patients, we all have different demographics that we serve, and those needs change where I would have spent a lot of my time focusing on other things that provided more value. So I might have had a hospital that had 3 different disease conditions that were treated more heavily than another hospital. So I might have focused on really formalizing the care and the way that the technology enabled the clinicians to provide better care, spending the money in that way, and allowing that connectivity and some of the goals of meaningful use to still be achieved. But instead, I was following this standardized menu that may not have been 100% the best solution for my patient. In the patients of our facilities. So I think that the overall intent was good, and I think as an industry we've got to be much more innovative and push much further so that we don't have the bulk of our incentives and work on a daily basis being dictated by regulatory mandates versus innovative solutions that are really going to benefit the patients that we care for.
Right, that's great. On to the next question. Craig?
Yes, this question is really about healthcare, IT, efficiency and speed, as well as innovation. When the Healthcare.gov had its issues, I think the public would have understood issues like that if it were 10 years ago when the internet was sort of coming on and people were getting their .com sites up. Feels like it was inexcusable because it was 10 or 15 years into an industry. But my question is, do you all see that IT is borrowing from other industries to learn their lessons to really become efficient and speedy in innovation? And do you also see innovation being driven through IT within the healthcare industry?
So Darrell, since you're the newest to health IT, what do you think about that question? What are we learning enough or no?
I would say we're trying to learn from other industries. So for example, using methodologies like Lean or Six Sigma for for developing IT systems. I think we need to continue to do that kind of cross-pollination. And then your other question about IT driving innovation, I think yes, and I think it absolutely has to. For all we talk about, needing the business to drive things. In some cases, the business doesn't really know where it needs or wants to go, or how it can use technology to get where it wants to go. And that has to come from IT. And while there needs to be much more collaboration between the two, I don't think we can ever get into a situation where IT is completely subordinate to the business. I just want to actually get back to the question earlier about meaningful use. From the state perspective, we've definitely seen much more interest from providers fueled by the incentives from meaningful use. So it's largely been a positive, and the funding that was available through the HITECH Act, and also Massachusetts was the first state to apply for and receive Medicaid funding for for our HIE, has really allowed us to drive down the costs. So for example, the Lahey network, they're actually at some point going to direct their administrative traffic over the highway because we can do it much more cheaply than they could. The flip side of meaningful use is that, because it's spurred that level of interest, in some cases, providers have really been pushing us to be able to go faster than we've been able to go in getting them connected. I was saying earlier that getting a provider connecting onto the highway can be a pretty challenging experience. And so that's run up several times against, the dates when the attestations have to be done. So it's largely been a positive experience, but it has also been something that's pushed us a little faster than we've been able to go.
Mm-hmm. Did you guys want to comment? I wanted to get one more question, and then we can also talk about the other
Sure,
stuff
just
as well.
a quick response. I think that was another terrific question about innovation, and I think, as I mentioned, healthcare as an industry and most provider organizations really have not been very innovative. I mean, that's not been a hallmark of what we've done, and a number of other industries have. And I think how an organization can get a core competency innovation is not reinventing the wheel, and there are a lot of lessons that we're looking at and incorporating for what happened across a spectrum of industries that we can then incorporate. But having said that, I think a couple of comments. One, probably as cognitively complicated and complex a function as healthcare is in order to bring health IT to work effectively. That there's a need for speed to get this done, but one has to respect the complexity given what's at stake in terms of providing care for people. And also, some of the early lessons from implementing things like an electronic health record, where people did go rather quickly. It's a very disruptive technology, and if it's not done thoughtfully in a well-orchestrated plan, that changes a lot of processes and staffing and roles and responsibility, training and education and the like. All of the work wound up in the lap of physicians, who wound up getting overwhelmed, and there was evidence that care went down, the quality of care didn't go up. And so because of the complexity, and the technology is advancing, but it's still not close to the level of how care is delivered. There's really a mismatch between as advanced as technology is and how healthcare really works, and how a physician and other care providers work. One has to do that with a lot of care, and that kind of slows it up. But having said that, technology is the driver that's going to bring new business models, new services, new ways of engaging in patients. And what I do with my team, and what I've seen with some other CIOs, is it's a phenomenal opportunity in health IT for IT to assume that kind of leadership role as healthcare organizations need to become innovative and really take the next step, because we've kind of gone over the years from being an installer to an integrator to enabler, to really be an innovator to get to those new kind of business models that we're going to need to become fully effective digital enterprise.
Yeah, and one from a summary perspective, keep in mind that when we say information technology is behind, it's not necessarily the same as technology being behind. I mean, when you look at, a proton imaging and MRIs and diagnostic devices, et cetera, that's all good stuff, and we may be behind on IT, but our medical technology isn't actually that far behind. Can we take one last question, Nate?
Oh, just 1 minute.
All right, great.
That's all.
My question is actually related to data silos and how you get across the issues associated with that. Our area of interest is in billing compliance and trying to get better at that. And if you think about the right way to do it, really you want to look across your medical record systems to your billing systems and make sure that there's an alignment between what was done and what was billed. And also looking out into the industry and trying to even go beyond that, looking at the data outside of your industry about what is the emerging regulations, what are the risk areas, what's the government going after, and knowing what you need to worry about. So I don't know if anyone had any success stories to share.
Kristin, you want to take that?
Certainly. So from, I'll say from a revenue capture charge cycle process throughout the, everything from initial patient engagement throughout their care process, it's important that that flow be tied to the clinical record and the care that that particular patient is receiving, along with payment verifications, et cetera. So as you know, we move from a digital silo to enterprise, you're seeing many of the technologies that support the revenue cycle being fully integrated with the clinical so that more information sharing is occurring. Otherwise, it's, many of us are still running legacy systems that require a lot of interfaces to be able to accomplish that. And typically a lot of business rules to make sure those types of connectivity are going through to ensure that as a patient traverses throughout that process of care, that the revenue cycle is able to support that. So I think it's still an evolving area, and then certainly many of the newer EMRs have that fully integrated, but the organizations that are running legacy are still often have many bolt-on products that are accomplishing that through interfaces and then also manual verifications and audit in many cases.
All right. Thank you, everyone. If you have more questions, you can ask afterwards. Please, I would like to thank you all, the panelists and moderator, for this interesting discussion. Thank you. Thanks for the applause. Bye-bye.